Now.
Good afternoon. Thank you so much for coming. Thank you for joining us today. We're honored to have Dr. David Willis join us today as he brings decades of experience as a clinician, child health system transformation trailblazer, and national early childhood and home visiting policy leader at HRSA. Dr. Willis also worked as a pediatrician at Dornbecker Children's Hospital for 35 years and served as Oregon Pediatric Society's president from 2008 to 2010. Currently, he's a senior fellow at the Center for the Study of Social Policy, working to advance early relational health in child health systems and pediatric care. We thank you so much for your participation and for co-hosting the Reach Out and Read Discovery Call series. I'm also honored to introduce our Dr. Kate Clayton, who's our current medical director of Reach Out and Read Oregon, and is a practicing pediatrician at Kaiser Gateway Medical Office. During her residency at Oregon Health Sciences University, Dr. Clayton was introduced to Reach Out and Read and became an early advocate for the statewide program and has been instrumental in expanding its reach within the Northwest Permanente health system. Kate is a champion of Reach Out and Read as a tool of early relational health advancement and is passionate about teaching providers and families the importance of positive child caregiving interactions. She believes in the power that reading together as a family can have on the lives of our young residents and enjoys doing so daily with her own young children. We're incredibly grateful to have her on our team and for the time and expertise that she donates to the program. Thank you, Dave, and thank you, Kate, and the floor is yours.
All right, Kristen, if you can advance to the first slide, I'm just going to go over, kind of the learning objectives. I really want to thank everyone for joining us and to the Reach Out and Read team for being willing to host these meetings. Our goals today are really to bring it down to those first 6 months and how we can practice Reach Out and Read in a way that most effectively emphasizes and helps that early parent or caregiver-child relationship to blossom. And we have some wonderful speakers here today that are going to give us some perspectives on this and also their expertise in how they use it. So this is a picture of my daughter at 3 months of age. I have always been a super passionate reader, and I just thought it was the coolest thing to get her library card at birth and start checking out books. And I was surprised when I went to the Reach Out and Read meeting that there had been some early controversy about using a book in that initial 6 months of age. So I've been really curious about this since then. And that's another reason that I'm really excited to hear what our speakers today have to say about early literacy in those first 6 months of age. I am going to go ahead and hand it over to Dr. David Willis to introduce our first expert here.
Great, thanks, Kate. And thanks so much, Samira. It's such a joy to be with this great team of Oregon's Reach Out and Read team. And yes, this conversation is really important to really be thinking about, the earliest of childhood, about early relational health, and carefulness and cautions about the some of the unthought about assumptions we make about that earliest period of early development, and the tension about the role of objects, the role of books, the role of interactions, all about promoting well-being. And I've had the great pleasure of both meeting Mariana Glusman over years of her good work as a Reach Out and Read physician and pediatrician, and also Cynthia Frosch, who we've recently connected with through the work about early relational health. And Cynthia and I, have actually had some hours that we have spent discussing this issue of toys, early objects in the early relational space, and just this whole, what do we know, what don't we know? And how to be thinking about promoting early relational health, which of course is a relational experience. And how do we think about that if what do we know? So I'm just thrilled to first introduce Cynthia Frosch, who's an associate professor at Auburn and an endorsed infant mental health mentor and researcher. She earned her doctorate degree in developmental psychology, University of Illinois Urbana-Champaign, First doctoral fellowship at Center for Developmental Science at the University of North Carolina, Chapel Hill. Her research interests are early relational health, parent-child interactions from birth to 5, reflective practice. She serves on the editorial board of the journal Infancy, member of the Society for Research in Child Development, and the World Association of Mental Health. She has extensive experience as a trained researcher in observation, early relational health observation, attachment. So we're in for just a real treat. Cynthia, may I turn to you?
Yeah, absolutely. Thank you so much. It's great to be here. Thank you for the invitation. Let me see if I can pull up the slides and talk to you a little bit about the things that I think about a lot. Okay. All right, everyone see okay?
Yep.
Yeah, okay, great. So as David said, I'm a researcher at Auburn and focused on early relational health. Have spent a lot of time observing and thinking about interaction, how to capture dyadic interaction between parents and children, particularly parents and infants. So I'm really glad to be here today. When I saw the flyer announcement, I saw that it was going to be sort of about neuroscience. So I just disclaimer, I am not a neuroscientist, but certainly I'm very interested in neuroscience as it helps us understand what goes on between a parent and infant or any two relational partners is really more than what any one individual partner's behavior would tell us. Okay, so here we go. So first of all, just tell you a little bit about what I'll talk about, just why early relationships are important, what we've learned from developmental psychology, which is my training background, and neuroscience, thinking about maybe how can we take what we've learned about dyadic interaction and move forward, maybe in a new way, and think about interaction as related to context. And then I'll close with some possible implications for practice and reach out and read. So, I mean, David has really given us a tremendous amount of information about early relational health as an emergent, I would say even field. Before we started the official call, we were talking a little bit about Mariana's experience of how what she does has always been early relational health, even though it may not have had that term. And I think a lot of us are interested in this idea of social connection, responsive, reciprocal, and positive experiences between infants and toddlers and their caregivers, whether that be parents, grandparents, or other primary caregivers that are essential in children's lives. The National Scientific Council on the Developing Child, so out of Harvard, all of their working papers and their resources really underscore the importance of healthy relationships as foundational for all aspects of development. And I think that shift to thinking about relationships, not just important, say, for example, for children's social and emotional development, but also for their learning, their cognition, for their success in school, all those outcomes that have been associated with the quality of early childhood relationships, I think have contributed to us understanding just how central early relationships are to all aspects of children's development. I love looking at research that's about how infants, they expand their regulatory capabilities, that they become competent relational partners because of the experiences that they have in interactions. You may be familiar with research on kangaroo care or on close skin-to-skin contact, and how that can be really soothing both for infant, but then also for parent. So I just wanted to highlight Hardin's 2020 paper talking about how infants' regulatory capabilities are enhanced through positive caregiving, and how in their study that the dyads that were assigned to the close contact, the kangaroo care condition, that those dyads had lower levels of stress reactivity, increases in oxytocin, and that close contact associated with kangaroo care was linked to left frontal brain activity. And this was an interesting study because it was with full-term infants and their mothers, whereas some of the kangaroo care research that we've seen is more focused on NICU infants. And so this says, yes, these kinds of close contact experiences are important for full-term infants and their mothers as well. And what we've learned from developmental psychology and neuroscience, I think, is fascinating. Thinking about Ruth Feldman's work, which I think is kind of a classic paper in my mind, 2011, demonstrating that mothers and infants coordinate their heart rhythms during face-to-face interaction. And that was within a lag of 1 second. And I love that because it says, that there's something really powerful about those face-to-face interactions for bringing into synchrony, bringing into coordination, and very quickly this idea of heart rhythms. Also, Provenzi's work, I think, is really interesting because it applies a dynamic systems model to parent-child interaction, and is thinking about how the mother-child dyad can be described as a dynamic system. So recognizing that it doesn't stay the same, that there's change, there's flexibility. And I think from a prevention or intervention standpoint, that's a very helpful way to think about relational health, that it's a dynamic system that can change, that it's flexible. Another piece that I think that's really important to think about with early relational health and what we've learned from neuroscience is that infants are co-creators in the establishment and maintenance of interactive synchrony. And so when I think in messaging early relational health, when parents and caregivers see that their baby is bringing something to the interaction, I think that is a beautiful message of sharing and capturing the space between a dyad, because it's saying, yes, the infant is bringing something to me and I'm bringing something to the baby. And that really sets up that nice idea of co-creation in relationship. This quote from a 2017 paper by Liang, I think, is beautiful. Synchronized behavior creates social connectedness within human dyads, and even infants synchronize behaviorally with adults. So it highlights the competence of infants to be relational partners, and it emphasizes the value of social connectedness and synchrony. Their work talks about synchronization as being mutually regulated. And I think that's beautiful in messaging because it doesn't just say that it's the parent's responsibility to make everything happen. I think when parents are experiencing stress, maybe they've had early adversity, maybe they're not enjoying parenting like they thought they would, just pausing to talk about the co-regulatory experiences, the mutually regulating opportunities that happen when parents interact face-to-face, I think is very powerful because it says you and your baby are in this together. Let's see what you and your baby can do together. And I think that message of connection, we-ness, is really powerful. Leon's work also emphasizes gaze when thinking as providers, as reach out and read practitioners, what is important to message. And this idea of gaze seems to be particularly important from the neuroscience research, that gaze brings neural activity into mutual alignment for adult and infant. And so thinking about activities like reading, I think is really important here in alignment with neuroscience, because you're saying, okay, how can we encourage reading in a way that also promotes gaze between parent and infant to help bring that neural activity into alignment for both adult and infant. And that has implications for thinking about positioning and how we can talk to parents about how they enjoy reading with their baby, what feels comfortable, what positions are comfortable, and talking about the potential value of gaze there. Other things that we've learned, 2016 paper is particularly interesting to me as a researcher who's trying to think about what kinds of research paradigms elicit the kinds of parent-child interaction behaviors that are important for predicting outcomes. Within toy-based interactions, different types of toys may elicit different patterns of interaction. So if a parent is playing with an electronic toy with an infant, does that look different than with books? And does that look different than with what we think of as more traditional toys like blocks? So Sosa's paper here has been very informative in my own thinking. Some of my own work that really has been focused on shifting measurement from just looking at parent and child separately and trying to approximate the relationship to thinking about dyadic level behavior was based on emotional connection. And this was using the WEX, if any of you are familiar with the WEX, so the Welch Emotional Connection Screen. And what we found is that mother-infant emotional connection during face-to-face interaction, but not during toy-based play, at 6 months predicted mother-reported child behavioral outcomes 2.5 years later. So that was really important for us to be thinking about context and how face-to-face interaction and connection in those interactions might be particularly important for understanding child behavioral development. A paper by Walburn and Caldwin that I want to bring your attention to is actually based on adults, but I think has translational impact for anyone who works directly with children in an observational capacity. What their paper affirms is that the whole of an interaction is greater than the sum of its parts. So that dyadic interaction is not just the average of partners' individual isolated responses. So in their research, they had adult participants watch interactions that were dyadically based versus watching just one component partner's behavior. And so I think it's interesting in as a researcher and thinking about how do I observe interaction? Am I continually looking to isolate the behaviors, or am I really recognizing that what's going on is more than the sum of the parts? And I would suggest that that is applicable to clinical practice too. So when you're walking into interaction with a parent and child, are you seeing just the child? Are you seeing just the parent? Are you seeing the interaction between the two? So interacting individuals are not merely perceived as separate individuals in this research study, but were perceived as an interactive dyad. And I think that's a pretty powerful quote there. Other things that we've learned, I'm often asked about what I think about technology and how technology might be impacting parent-child interaction and early relational health. And maybe you're familiar with the tronic still phase procedure or still phase paradigm, where a mom and an infant are interacting face-to-face, and then the parent looks away briefly, and then looks back at the infant and presents a blank face. So like this, right, without responding to the infant, and it looks at how the infant tries to cope with that disruption in interaction. Well, a recent paper by Stockdale took that idea of the still face paradigm and modified it by having parents look at a mobile phone as an interruption in the interaction. And what they found is that technoference is what the term is that technoference seemed to elicit similar patterns of infant responding as found in other research with the still phase procedure. And so that's a really powerful indication, I think, to us to pay attention to how technology may be interfering with, interrupting, or distracting from parent-infant interaction. And the research also had parent reports as well. So technoference may blunt infants' emotional responses to parents' disengagement in ways that may be similar to infants with disengaged caregivers with depression. And that was one of the author's conclusions. And so you can see that quote, and I linked to all these different articles in the references to the slides that will be distributed to everyone. So all this evidence that's come out recently, and particularly papers from 2017, 2018, 2019, along with Feldman's work in 2011, really highlights, I think, for us, the power of looking at dyadic interaction as a whole, and rather than trying to just focus on individual relational partners. I think we know enough to say, looking at relationships and looking at particularly face-to-face interaction is really important for understanding development in many domains. What there's not a lot of emphasis, I think, is on understanding how those mutually positive experiences or even mutually negative experiences impact the caregiver or the care provider. And David and I have talked about this in refining and thinking about definitions of early relational health, in that we often think of early relational health as just having impacts on children. But early relational health experiences have impacts on caregivers too, and thinking about how to dialogue with parents about that, how to invite wondering about impacts on parents and how that may differ with different children within families and so forth, I think is very important. So moving forward, I mean, as a researcher, one of my key areas of interest is using research to help us capture parents' actual experiences, right? So if in our research, we are bringing parents into a lab and asking them to do a task that doesn't mirror their everyday experiences, are we really capturing their interaction in a way that's meaningful? So context, interaction, assessment and all is something I spend a lot of time thinking about. So I wanted just to highlight measures that are focused now on really trying to capture that space between adult and infant rather than rating parent and infant separately or a care provider and infant separately. So measures like the WEX, David's early relational health screen. These different measures are really focused on the dyadic level of interaction, capturing shared mutual features of interaction. And I think that from a research and practice standpoint is really important moving forward. Another question I have is, does face-to-face interaction quality differ from toy-based interaction quality and its ability to predict later child, parent, and relational outcomes? And so that earlier study I was telling you about that I conducted with my colleagues at both Columbia and University of North Texas, we found that it was really emotional connection rated in face-to-face play that mattered for later behavioral outcomes. Another question is, how do patterns of parent-infant interaction differ in stationary versus mobile situations? This Franchak paper does a great job of talking about how, as researchers, we often bring people into situations, place them face to face. But how often does that happen in actual context, say, for example, in the home, where a newly mobile infant, a new crawler, a new walker might be all over the environment. So sitting face to face and interacting for a long time may not be at all what's happening in the environment. So that paper really got me thinking about that and how patterns of interaction differ with motor development, for example. Always interested in how behavioral and survey data inform and complement data from neuroscience. So are what we thinking and seeing, does that match to what parents are reporting about themselves? I think that's really interesting. Thinking more about fathers, the role of fathers, father-infant synchrony, and synchrony at multiple points in development. What happens if you're synchronous at one point, not synchronous 2 months later, synchronous again 2 months later? What are those different constellations of patterns of synchrony? What does that mean for outcomes? And then also thinking about infants are nested in a variety of relationships. So how do those different patterns of synchrony or connection, how do those interact to shape development? And also how, what do infants bring to the table? Understanding more about that in terms of temperament. There was a recent paper by Garstein that addresses this. Developmental delays or disorders, trauma experiences, right? Parents and infants bring their own unique characteristics to relationships. And I'm particularly curious in how they independently and jointly contribute to early relational health. In terms of practice, I think it's always wonderful to see pictures of babies interacting with books. I'll show you a quick clip real quickly here.
Are you reading? What are you reading? About the neighborhood? Oh my goodness, what's on that page? You reading? Mm-hmm. We all help each other. Yeah, we all help each other. I know, books are so awesome. Books are so awesome.
So I love that video because I think it beautifully illustrates the value of relationally focused interaction. So the book is there. It's an object in the interaction. But what you see in that interaction is that it's relationally focused, even if it's object facilitated, right? So this is a way that I'm wondering about how we can take that neuroscience research and that developmental research that talks about the value of face-to-face interaction and apply that to situations like shared book reading. I would say this is a shared book reading interaction, even though the mom might be cooking dinner, she's taking time to pause and interact, and the focus is really on their relationship. And so I think some implications here in for you all as clinicians and practitioners and people who work in the Reach Out and Read community is thinking about wondering together with parents about their baby's experiences. This mom, you know, in talking with her is like, this is how my baby loves books. It's just about my baby enjoying books. Inviting and honoring family and community voice, I know it's something that David is working on a great deal, and thinking about how family and community voice can be included in our assessment work, in our approaches to delivering Reach Out and Read, and thinking about messaging what's important to families, and really listening to families, because that's really where we're going to have the most impact, is if we're in partnership and we're not in a vertical relationship, that we walk alongside of families. So again, and in terms of thinking about ERH and Reach Out and Read, just thinking about delivering relationally focused, object facilitated or book facilitated interaction, I think is particularly promising. And as individuals who are committed to reducing health disparities within our communities, I think we really need to think about relational health as a health disparity, and how we can collectively pull together to message relational health as something worthy of consideration, just as much as we might be thinking about obesity, for example, in early childhood, and standing with families to partner in our shared mission to promote health. So I have lots of different references at the end of my presentation that I'll share, and just want to be mindful of my time, and so I'm at the end. So interactional synchrony is co-regulated. The whole of dyadic interaction is greater than the sum of its parts. Context is important, and let's value voice of our children, families, providers, and communities. So thank you for having me today.
Cynthia, that was fabulous. Thank you. We'll have time for, I hope, for some discussion, but I think I'll turn back to you, Kate, to introduce Mariana.
Yeah, great. I'm just so thrilled. That was wonderful, Cynthia. Thank you so much. And I'm also thrilled to introduce Dr. Mariana Glusman. She's an assistant professor of pediatrics at Northwestern University and a primary care pediatrician at Lurie Children's Hospital Uptown Clinic, which is a community health center. She is also the Reach Out and Read Illinois medical director, and among many other leadership roles that she's had throughout the years and has currently, and other adventures that she's taken throughout her life, she is also a mother and the author of a beautiful book called I Love You Like Sunshine: How Everyday Play and Bedtime Stories Build Love, Connection, and Brain Power. And we invited her today to discuss some of her reflections and thoughts on practicing Reach Out and Read, on the writing of this beautiful book, and how she uses Reach Out and Read in that 0 to 6 month age range. So you can take it away, Mariana. Thank you so much again for joining us.
Excellent. Can you hear me? Yeah, excellent. So thank you so much for having me. I am super excited, and thank you. This is great to go, to be talking about this in the context of relational health. I think has been really exciting. So next slide, please. I do want to mention my conflict of interest. I am the owner of West Walking Publishing House. Next slide. Which is the publisher, the sole publisher of the sole book that it publishes is I Love You Like Sunshine. This has kind of been a work of love for me. So just a little bit about myself. I started out thinking about literacy because of my daughter. She was born, this is Abby, when she was little. She's 29 now. She was born when I was a 4th year in medical school, and she was 6 months old when I started doing my residency. And so I started learning to be a mom as I was learning to be a pediatrician. And in all honesty, reading became one of our favorite things to do together because it was something that I could do lying down. I would come home and just lie down, and I was exhausted after coming home from my long residency hours. So it was something that we could do for hours, and I didn't have to spend a lot of energy. But one of the things that I noticed as I was seeing her develop and comparing her to my patients is that they were not developing as well as she was. And I started wondering, well, why is that? What is it about my daughter and my patients? My patients are loved, they're cared for. And then I started wondering if it was all those books that we've been reading all along. And just around then in 1996 is when I came across Robert Needleman's book, just realized that Reach On and Read was really exactly at the crux of the matter. In that next page, next slide. And I really just dived right into the Reach On and Read family and became part of it ever since. I've been involved in a lot of different things, including sort of starting to think about Reach On and Read at birth. So that's what I'm going to talk about today is what are the strategies that you can use to develop language and relational health, and in a way that is empowering and it doesn't make patients or parents feel guilty. Next slide. So why Reach On and Read at birth? It stresses the importance of the message, right? There are so many things that we can talk about, and if we choose to talk about literacy in the same breath as we talk about breastfeeding and sleep safety, then wow, it must be really important. It also adds 3 or 4 more touch points to our talking about literacy and language, because of those early visits. And we know that starting earlier can oftentimes have more impact than later interventions. Next slide. There's also new evidence on brain and language development that's come out in the last 10 years or so, talking about how that serve and return interactions are really crucial for synapse formation. As well as all the things that we were just talking about with regards to the connections and the dyads and the relational health and nurturing relationships, which is also a growing field. And finally, this is the first time that we can really tell parents something positive to do. I think a lot of times people worry about starting Reach On and Read early on because there's so many things that we're talking about. The parents are stressed out. There's one more thing for them to do. And I actually think that's exactly the reason to start Reach On and Read in those first visits, because they're so stressed out. And this is something that we can actually give them that they can really enjoy and help their child bond with their child. So I think it's a gift that we don't need to hold off until 6 months. Next slide. So how do you do this? Next slide. The key is that we want to give messages, empowering messages like right from birth, babies are listening, looking, and learning. So find and enjoy, that's important, these everyday moments when you can talk, sing, read, and play together with your baby. Next slide. So other messages that I like to give, and every visit is different, so whatever comes out, these are just different, a menu of things that you could potentially say to a parent, like your baby loves your voice. The more you talk with her, the more she's going to learn. Or here's a book you can share with your baby. Look, you can look at pictures together and they'll give you lots of things to talk about. Or reading is a way to expose your baby to more and different words. Next slide. The key, as we all know with Reach On and Read, is using those teachable moments, right? We always talk about how at 6 months, when you come in and you give the book to the baby and the baby puts the book in the mouth and they chew it, and the parent gets really upset because while they're chewing a book, they're not supposed to chew a book. And that's when you can say, no, this is exactly what they're supposed to be doing with the book. And this is where you can model using the book. You can use the book as a tool for development, right? So that's something that we talk about a lot during when we talk about Reach On and Read, right? But if you think about giving a book to a newborn, that's not the teachable moment, right? The newborn is going to do nothing with the book. So giving a book at the beginning of the visit doesn't really make as much sense. So I found that using the exam is a great time to do all that modeling of child-directed speech. And the key is really explicitly stating what you're doing and why you're doing it. And that's how you make it powerful and actionable. So next slide. So how do you model during the physical exam? The people that are taking care of newborns are probably already doing this. You've been probably doing this all along. Asking questions, saying, oh, you are so cute. Look at those cute little dimples on your elbows. Or, talking about how much they've grown or pointing to their body parts. But it's also good to show all of those those relational cues that we were just talking about before, about what is all those serves that the baby's doing that the parent needs to return that oftentimes go unnoticed. Explaining to parent, oh, look at how wonderful, look how alert she is. She's looking at you. She loves your voice. Look how she turned to listen to you. So the key is doing this with intention so that the parents can understand that's something that they can be doing as well. And, again, we mentioned the positioning, right? Sometimes people are worried that giving a book at the beginning of, in those first visits would interrupt that nice face-to-face interaction that we really want with those early babies. And the fact is that it doesn't have to. It's about positioning. You can see in that middle, next slide. In that next, that middle photo on the top, you can see that beautiful face-to-face between the mom and that baby. And the book can be on the side. Again, it's a tool that can help you expand what you say. Next slide, please. So each visit is going to be a little bit differently depending on the development of the baby, right? So we can go visit by visit. So next slide. In the beginning, that first visit, the parents are scared, they're exhausted, they're overwhelmed with information. The baby probably sleeping all day and awake all night. But babies do a lot more than we give them credit for. They calm when held. They turn to sound. They look with their eyes. And Bright Futures, which is what we're supposed to be doing as providers during well child checks, says that we should be really beginning to talk about early brain development and talking and singing with babies and creating those nurturing routines. So adding a book at this early visit really isn't anything more than what we're already supposed to be doing. Next slide. So because this isn't very busy, you may not have time to talk about everything, but the key again is modeling and showing that interaction. Singing, you can talk about avoiding electronic devices. It can be something that they can do with their older sibling. Next slide. I think next slide, please. Oh, there's, thank you. I think one big thing is acknowledging that this is not easy. Being a parent of a newborn just feels like literally an out-of-body experience, and talking with a newborn that doesn't even smile can be really hard. So really saying that, I think, is really important, so parents don't feel like there's something wrong with my baby or there's something wrong with me. I don't seem to be enjoying this back and forth communication like I'm supposed to. So really saying, well, babies just don't focus the way older kids do. And we talked a little bit about positions, etc. So next slide. As kids get a little bit older, a little bit more organized, and the parents begin to feel a little bit more on top of things, you can begin to talk more about the routines and focus a little bit more on this topic on relational health and the books. Next slide, please. Really kind of encouraging, again, the talking, singing, reading, pointing out how great eye contact the baby's making, how you can start having conversations. And again, I think that, I mean, this may sound repetitive, but really I'm purposely being repetitive is because it is really, really important to model and to show parents how to do this rather than tell them to do it. Next slide, please. This is an example. One of my first babies that I gave a book to, this mom actually had depression. She was crying when she first came in. She was really worried about the baby not just wanting to breastfeed all the time, not wanting to do anything, sleeping. And then this was when I was beginning to think about doing reach out and read at birth. This is a 1-month-old. And I said, do you mind if I take photos? Because I'm doing this presentation, I need some photos. And so then I gave the book, I took out my phone to take photos. And this is what he did with this book, right? Just directly looking at the book, looking at not just one page, different parts of the book. And the mom too, you can see, talking about relational health. This is a mom that literally had been crying 10 minutes before. And that book really helped to sort of change the dynamic of what was happening between the two. For the 2-month visit, these babies are smiling, they're cooing, there's so much more fun. And I think that parents also begin to feel a little bit more comfortable in as what they do. Again, Bright Futures still talks about, talking and singing and really kind of beginning to look at your baby's temperament and personality and developing nighttime routines and naps. Next slide. And yeah, this is the time when you're going to give vaccines. So there's other stuff to talk about. But again, pointing out signs that the baby's listening and responding and how great they're cooing. And also pointing out what a great job the parents are doing, I think is a really important thing. I think a lot of times parents feel overwhelmed and don't get a lot of positive feedback. So again, this is a good time to give parents that kind of pat on the shoulder, saying, you're really doing a great job. Next slide. And then 4-month-olds there, again, we're confident and really all over the place. I'm going to just go to the next slide, just for purposes of time. This is a good time to begin to really reinforce the idea that babies need interaction and that they can't get this from a TV screen. This is almost like anticipatory guidance, because pretty soon, this is around the time when parents really begin to, at least in my experience, start showing more screens to their babies when they're crying, and as ways to pacify babies. So a good time to sort of really talk about, wow, look at all the way, this is a great conversation we're having. This is the way you grow your baby's brain. And, that phone or that TV just doesn't do the same. It's not nearly a good way of learning, just the way as much as your interaction with your baby is. Next slide, yeah. So again, it's about the overarching messages that babies are learning from the very beginning. It's through serve and return interactions, and positive interactions are really, really important. And the book is just a way to encourage that interaction and expose to more language. Next slide. This is a sheet that I can make available that Anna Miller-Fitzwater in Wake Forest and I developed. Basically has a lot of the information that I just shared with you in those last slides. What babies are doing in each of the weeks and what kinds of messages you might want to give for kids of different ages, specific examples of modeling that you could do, and books that you might want to try to recommend. Next slide. Briefly, some research highlights. There is not a lot of research on this area. I am going to sort of briefly mention there's some studies that have been done, again, by Anna Miller-Fitzwater in Wake Forest, by Jen Guevara at CHOP, by Elizabeth St. Clair and Ellen Stevenson, right there in your hometown, and who really were some of the first people that were doing research on this topic. And what they've found is that Reach Out and Read in the newborn is easy to implement. Providers enjoy it. It doesn't usually take a lot of extra time. And in fact, providers feel like they have enough time to do it. some of the studies found that reading with their infant, starting Reach On and Read in the first visits increased the amount of reading that parents were doing with their babies as compared to regular Reach On and Read, and they had a greater number of books at home and greater frequency of earlier initiation of reading. The study by Ellen and Elizabeth did not find differences, but it was also a really important study in the sense that, again, people have been worried about giving a book as being something that actually is detrimental. And the fact is that it's not detrimental. This is, that was an important finding as well. None of the studies have found changes in terms of language development, but I don't think that that's surprising at all because, it's not a big intervention, and it's also in comparison to Reach On and Read already. But maybe we need to do more, in fact, we do need to do more research, and maybe we need to look a little bit more at what are the best practices for doing Reach On and Read in those early visits. So for example, I'm sorry, I'm still in the research. For example, is all this modeling, does that make a difference? Is there an effect on social emotional development or attachment or stress? Next slide. So I'm going to finish just quickly talking about my book, I Love You Like Sunshine. And when I started thinking about my book and when I started thinking about doing Reach On and Read in the newborn visit, I thought, well, what's the best book that I want to give to a child? And then I couldn't find the right book, so I decided to do it myself. I knew that I wanted to have diversity in the photos, which actually, by the way, my mom is the photographer, so I have to give a shout out to Dr. Kilner. And I wanted to make sure that in the front cover that featured a Black mom and baby, because in fact, even though there's been a lot of changes in the past 5 years, at the time, and this is not long ago when I started this book, there really weren't very many Black moms and babies on covers. Of course, I wanted to talk to parents about building babies' brains. Next slide. And all my interest in all the brain stuff. Next slide. And because I wrote it with Reach On and Read in mind, I put at the end a section about newborn care, peeing and pooping and sleep and safety and when to call your doctor, so that pediatricians and providers and parents at home could just turn to the back of the book and use that as talking points for the visit. Next slide. But really, my biggest goal was to give parents information about, without overwhelming them, and making them feel guilty. Next slide. I wanted to share with parents things to know, but I also wanted to give them things to try and things to notice, and that's what I did on the margins, and give them positive parenting messages like, what is the most amazing thing you notice when you look at your baby? Next slide. I wanted to include reading and how to do it without being all shooty about it, because somebody said to me that if you live by the shoulds, you live a shitty life. So to really making sure that you tell people what they can do, not what they should do. Next slide. Of course, I wanted to include fathers. Next slide. And to acknowledge, like I said before, that it's not easy to talk with a newborn. Next slide. And along the same lines, that parenting is not always that delightful, blissful experience that you think you're going to have when the baby's inside, and that you can be depressed, and that's the reason that happens, and it's normal, and how to get help if needed. Next slide. And my ultimate goal was to give parents really some concrete suggestions of how to interact with their infants without the guilt and empower them to be their child's first teacher. Next slide. Yeah, and to reassure them that it's all going to be okay. Just take a deep breath. You're going to be a great parent. This is something, actually, I can't tell you the number of times that I open to the last page of the book when I'm talking to parents of newborns, and there's a big sigh, like, oh, thank you, because there's just so much stress and so much worry, and that's normal as a parent of a newborn. Next, so again, sort of just to wrap things up, the goal is to start reach out and read in those first visits is to encourage those reciprocal interactions, and books are a great tool to do this. The other is to model those serve and return interactions, and the physical exam is a great time to do this, and to increase the number of times that we give these messages. We are, as healthcare providers, have a unique opportunity to promote these messages from the very beginning. And I have found that doing this has been incredibly rewarding, and I hope that you do as well. And thank you to Anna. And I don't know if I have time. I could, if you would like, read my book.
Yeah,
Or should we do questions?
I'd love to hear it.
All right. I love you like sunshine. Yeah, I'm just going to read it because you're just going to have to imagine the pictures. I look at you when you're asleep. I can't believe you're here. Your tiny nails, your lovely lips, your precious curving ears. I look at you when you're awake and you look back at me. I read your books and point things out, so much for you to see. You have different cries and sounds you make to tell me you're upset. I pick you up and hold you close, and you relax into my chest. Your expressions, ever changing, show all feelings in one place. Curious, sad, surprised, and puzzled, pass like clouds across your face. There's so much I want to show you and teach you about the world. I sing to you and play with you and fill your days with words. I tell you stories and you listen. You turn when you hear a noise. You're not even a month old yet, and you recognize my voice. We take turns cooing and talking, and you really get excited. We have long conversations, though they often feel one-sided. I'm really tired, I won't lie, and I'm sometimes lonely too. I get sad and want to cry, but I feel better holding you. My sweet sunshine, I adore you, and I promise from the start that I'll talk and sing and read and play and love you with all my heart.
Thank you so much, Dr. Glusman. Beautiful book. And Reach Out and Read Oregon did send a couple copies to that book out to all of our sites. So everyone should have it. Samira's got one right there. We'd love to open it up for questions if people have time or comments. There's a lot of comments in the chat about how beautiful that book is and how much everyone loves it.
There was one question about how to get a copy of the book, and I'll be sending out information about that to everybody on the call and those who missed it as well. And Christina, did you have a comment from, I think we have an anonymous comment from the chat. Did you want to share?
Oh yeah, I just wanted to give some space for comments made a little bit earlier that we can just kind of sit with, or you can provide feedback with as well. But a participant just wanted to kind of point out that a lot of the research that was mentioned is specific to kind of the white dominant culture, and that Native communities, for example, have been doing kangaroo care and dyadic interactions since the beginning of time. So just making sure that, calling things emerging science or emerging practice when it's natural and given in existing cultures, just to be aware of that. And then just, making sure that we're talking about emerging practice, that we also recognize that's actually cultural medicine and wisdom that's been around forever. So just making sure that is acknowledged as well.
Christina, thanks for calling that out, because
Yeah,
I think
absolutely.
that their historical, indigenous, cross-cultural practices that are very relationally centric, sensory, regulatory, affectively present in so many cultures over so many years. Then you ask the question, like I raised at one point, which is given the dramatic shifts of the degree of social contact of infants in the last generation, the amount of relational interaction opportunities, like Bruce Perry talks about, what used to be 4 adults to 1 baby in clans, to now 1 adult and 4 babies or more in terms of institutionalized policy. And what does that do to the social, regulatory, and interactive space? So Cynthia, that brings me to a question. You said something that jumped out to me, Mariana. I'm also interested in your thought. You mentioned the importance of gaze. And, you know, I've been around a long time. That's not talked a lot about. Now, I'm aware, and researchers are looking deeper and deeper into the dyadic facial interaction, the eye gaze, the criticalness of that to so many attachment, regulatory engagement processes. But how do you think about that? And more importantly, perhaps Mariana, how do you talk about that with families? Because you know my concept of my worry about toy pollution, which shifts the gaze. And so many toys now are very stimulating, either auditorily or visual, right? And I personally have witnessed, and there's some research that shows that toys that have high degree of visual or sensory stimulation actually may be preferred than to facial gaze. What does that mean? So how do you think in pediatrics about talking about gaze still matters? Think about TV, the cell phones or toys. Are there messages that we ought to be thinking about, if not elevating, about the gaze of babies to people is a critical experience? And how do we think about that? I'm interested, Cynthia, your thoughts. Mariana, your thoughts.
First of all, I think that's a really important point, but I would just, if I could just take a step back to the question that came in through the chat. I just think that it's such an important question, and I just really appreciate that being brought to the table, because as a researcher and in presentations, small and large, like I try to think very critically about how to talk about things in a context, in a cultural context, in a community context. And I know that I do it imperfectly. So I just really appreciated that whoever sent that comment across. Like, I think in every discussion of a finding, we said, it should be followed by, and this was the sample, and this was the approach. And I just think that will bring a lot to helping us think about how so much of our research has just been focused on white, Western, industrialized, communities, and how much we're missing in the conversation. So so thank you for that. And so David, going back to the question of gaze, I think you're right. I think sometimes the more distracting kinds of toys are preferred. They make sounds, they're visually appealing, they draw the eye, they draw the attention. Some toys, even after you don't play with them for a little while, will give you a little reminder to bring your attention back to them. And I think that we become used to that kind of interaction. I think Mariana's book does a really nice job of saying, look, sometimes the conversation might be one-sided when I'm looking at you, but that doesn't mean that interaction still isn't important. So I think, David, it's a really important question, and I think it's a conversation that if you're able to have early on in your visits, which it sounds like, Mariana, is what you're talking about, doing it very early on, about how much your baby wants to interact with you, and it may be one-sided sometimes and so forth. I think that kinds of anticipatory guidance and encouragement probably will go far.
Yeah, I completely agree. And I think also, just to make one comment about the first comment, I completely agree about the importance of looking at things in a cultural perspective. The one thing that is a little bit different, I mean, every culture is different and no culture has a monopoly on loving their child. And some people express their love in different ways. And I think that the gaze and the touch, I think, is really very universal. The language is not always as universal. And different cultures are more verbal than others with their babies. And that's an important thing when we're thinking about language development in the context of growing up in the United States, right? It's different if that you growing up in your culture, in the country where everybody has the same exposure, then you're not behind, right? And again, this is not a race, but the problem when you start behind is that you stay behind and you get put on your track, and that puts kids in a disadvantage. So the key is, how do we incorporate what people are doing already beautifully and then layer on ways of talking and interacting verbally so that it encourages things and it's additive, and not like you should not do this, you should do that. Again, just promoting it in a really loving way. And to the point of electronics, I mean, you see them all the time. The baby starts crying and immediately the parent takes their phone out and puts it in the baby's face. And one great way to actually address that is to pick up the baby and calm them down, like to model for them, right? I've done that before. It's a little harder with COVID when I'm not really supposed to be picking up babies and cuddling them, but rather than, I mean, you don't want to like snatch the baby from the parent's arm. It's like, oh, my honey, wait, let's see. And then you can say, oh, look, you don't need a phone. You can calm right down. Let's sing a song. So doing it in a positive way, you should not use that phone without, parents don't need to feel guilty about being parents. I think that's really helpful because we do see it all the time. And unfortunately, like you said, those phones, the TV are just incredibly, kids love them and parents think that they're teaching them and that it's educational, and it's not. And so we're in a really important place to be able to dispel that myth.
I agree. All right, well, it is 1 o'clock. Should we sign off, everyone? Thank you so much for joining us. I really appreciate it, and I loved hearing what everyone had to say.
Thank you so much.
Yeah.
So.